So currently, in terms of how we choose our therapies for HER2-positive metastatic disease, again, it's very clear that for first-line therapy, trastuzumab, pertuzumab chemotherapy should be the standard of care, and second-line T-DM1. Again, the data are very clear for those. In third and later line, the standard of care is really not clear, and based on patient preference, cycling through one of the many different chemotherapies that are available is very reasonable. The important point is to continue your HER2-directed therapy, either using trastuzumab or lapatinib. I should point out that at least my preference, based on the available data, is that single chemotherapies should be preferred rather than doublets. There really are no data to say that using combination chemotherapy in addition to HER2-directed therapy is more efficacious in the long run than using sequential single agents, and definitely using doublets of chemotherapy increases toxicity. So, I think using sequential single agents makes the most sense, and you can get, reasonable efficacy from doing that. I think what we're all excited about is that there clearly are several new drugs that are going to be approved or likely to be approved in that third and later line setting. And at that point, we're going to have to, as a community, figure out how best to sequence these newer agents. But right now, chemotherapy sequentially is, along with HER2-directed therapy, should be what we're doing.
One of the challenges is going to be how to employ all these different drugs that we're likely to have available to us. Obviously, when you have two drugs or one drug, it's a very easy decision making. You use what you got. But if you've got 5 or 6 or 7 different things, how to optimize things. So I think one of the drivers of decision making is going to be overall survival. So when you look at the trials that have been conducted to date, one of the reasons we use a taxane, trastuzumab, pertuzumab as a first-line therapy is it very clearly has a survival advantage. And that is employed as first-line therapy for most, not all patients. And TDM typically follows in the same justification. There was a survival benefit that was demonstrated in the trials evaluating TDM1. So as we go forward, post pertuzumab, trastuzumab, and TDM1, we'll have another group of drugs that I expect to be on the scene soon. And we'll have to determine whether they offer an advantage over other standard options, which would typically be trastuzumab and chemotherapy du jour, whatever you want to use. And I think that what we're seeing in the trials that we've talked about today is that these drugs have a lot of activity. They're unique either in design, like antibody-drug conjugates, or bioengineered trastuzumab that may more selectively identify certain subsets of HER2-positive disease that are more it would be more advantageous to use a drug like margetuximab in. And there may be patients that you select a certain drug based on where their disease is. So if somebody has CNS mets, you use tucatinib if you had it available. So I think that part of the decision making is going to be based on characteristics of the patient, what they've received in the past, and then applying the menu of drugs you have available to that given patient. And I think that, the other thing that's going to impact on this is so many patients are getting now, based on, say, the affinity trial, pertuzumab, trastuzumab in the adjuvant setting. That may dictate what comes first. It may not be pertuzumab, trastuzumab if they develop metastatic disease. If somebody gets preoperative therapy with trastuzumab, pertuzumab, happens to have residual disease, they're going to get TDM1. So if they relapse quickly, they've already gotten 3 of the most active drugs, you may make a decision not to go back to them, but use one of the newer drugs. So I think it's going to be an issue that the clinician has to look at the sort of holistically what the patient has gotten, what the time frames are, what the clinical situation, brain mets, no brain mets, other comorbidities that may determine what the best choice is for that patient when they develop metastatic disease.
As we head into the next year, it's going to be very interesting to see how the sequencing and management of HER2-positive metastatic breast cancer changes, because I believe that we have seen some real practice-changing data emerge at the end of 2019. I do believe we are going to have available tucatinib and DS-8201 very shortly. And so a natural question is, how do we utilize this in our standard of care practice of patients with metastatic breast cancer? We've not yet seen data that pushes out frontline use of THP, and I believe that remains the standard regimen in the first-line setting, nor have we seen data that should push out TDM1. Both of those regimens and therapies have been supported by phase 3 randomized trials that have shown survival benefit. Keeping in mind the frontline therapy of THP is now associated with an OS of 5 years almost. So I don't think we have good enough data yet to bump that regimen. We need to actually go head to head in a trial before we do so. Where it gets a little dicier and is less backed by evidence is, how do we choose if we have both tucatinib and DS-8201, our third-line regimen, our fourth-line regimen? I think many of us will utilize the CNS metastases data that we saw and that will continue to emerge from HER2 Climb. I would be compelled to probably sequence tucatinib earlier in a patient who has CNS metastases. But if a patient has a lot of disease in their body and I really need a response, I might do DS-8201 earlier, given that objective response rate was so high, and especially high if you look at the forest subgroup in Destiny for patients who had fewer than 3 lines of therapy, were now greater than 70% objective response rate. But the truth of the matter is, I think all our patients are going to receive both these therapies ultimately when their disease progresses. So we don't have data to tell us that one way is right for every patient who is having disease progression.